Hello everyone, my name is Jeff Taylor and I'm here at the 25th Annual CROI Conference in Boston this year, snowy Boston. And today I'm here with Dr. Tim Wilkin from Cornell Medical Center in New York and Dr. Margaret Borok from the University of Zimbabwe, is it?
That's right.
Yes, so thank you so much for joining us today. And we're talking about HIV malignancies. Obviously over the course of the epidemic, cancer has been a huge issue and it's changed dramatically over the years. Especially HPV, I think, has arisen. First, it was a concern for cervical cancer. It still is in many parts of the world. And in the U.S., I think it's kind of risen again. So, Dr. Wilkin, I know you've done a lot of research in HPV. Would you like to speak about what appeared to be the most exciting things this year?
Thanks, Jeff. So there seem to be several important HPV-related presentations. So, the risk of tooting my own horn, I'll start with my own presentation. So I was fortunate to present the results of ACTG A5282. We were really trying to investigate an HPV test and treat approach for prevention of cervical cancer. So screen a woman with an HPV test, which is our most sensitive test for pre-malignant lesions of the cervix, and then if she's positive, give her same-day treatment to help prevent cervical cancer in the future. So we conducted a study at 13 sites in 7 countries.
Wow.
So what we did was we randomized women who had HPV, cervical HPV present, and were appropriate for cryotherapy, the treatment we used. So the lesions couldn't be too extensive. They could be needed to be able to be treated with cryotherapy. So we randomized them to either that strategy or the traditional pap smear approach, where you get a pap smear and then you get biopsies and colposcopy if it's abnormal, and then a LEAP treatment if she has a pre-malignant lesion.
And LEAP stands for?
Loop electroexcision procedure. It sort of treats the whole transformation zone of the cervix. And so, to our surprise, what we really found was that there was no difference in those approaches. So we randomized 288 women and followed them after that treatment up to 2.5 years, and really no difference in the treatment outcomes. So on one hand, we were disappointed because we thought the HPV test and treat, by treating everyone, we would get better results. But on the flip side, the pap smear approach is really complex. It takes a very well-functioning pathology laboratory. The woman has to come back 3 separate times to really get the prevention services, so it can be very difficult to implement, it's difficult in places with lots of resources. It's especially difficult in places where there are few resources. So we did in some ways show that this was a reasonable approach to do instead of a pap smear approach. And so there is actually now an HPV test that you can get the results within an hour available in sub-Saharan Africa. So we really do have an opportunity for test and treat. And that's what we're going to actually investigate in a future AMC study that's going to be starting later this year, AMC 099. We're going to be looking at HPV test and treat with and without HPV vaccination.
Now, is that test also available here in the U.S.? Or
it's not approved in the U.S., so it's an example of a test that I think is actually really attractive and easier than some of the tests we have here. That's just available overseas. It uses the same platform as the tuberculosis expert test. It's really the same machine that's used, so it's a nice option.
Excellent.
Yeah. And then there was a nice analysis of the potential benefits of widespread 9-valent HPV vaccination in South Africa, just a single dose. So we don't know if that works for sure, but they were just kind of modeling some possibilities, and it looked really, really attractive to reduce the rates of cervical cancer. There are also a couple studies that looked at response to treatments for HPV pre-malignant lesions, and really a common theme of how difficult it can be to get rid of these lesions either in the anus or the cervix, and some analyses that looked at what makes people more at risk for recurrent disease. And then one last thing that I thought was particularly exciting, there was a large study from the VA cohort. They looked at thousands of people and looked at people who were on a statin, to treat cholesterol or prevent heart attacks, well matched to people that were not on a statin. And then they looked at the effect on cancer, and really across the board, cancer seemed to be reduced by about 50 to 60%, or about 50% for people on a statin.
So this is any statin, not any particular
Yeah, we don't know particularly if one type was more effective because they're differing potencies.
Right.
But yeah, that was pretty interesting. And specifically for HPV cancer, it's significantly reduced anal cancer in the population. So it's something that's, will maybe more widespread use as a result of the analysis.
Excellent.
Yeah.
That's exciting. Well, Dr. Borok, you're based in Zimbabwe in Southern Africa, and it's a very different situation there. Are you going to speak to some of the issues that you face as a clinician and cancer treater?
So it is different, and from our point of view, some of the work that Tim's been talking about, the A5282 study, has been really interesting and exciting. Cancer of the cervix is our most common cancer by a long way in women. And
that's because people don't have access to
there's no widespread screening, and there's certainly no vaccination. So the 099 study that the AMC we're hoping to roll out later this year is going to be very exciting. The country, Zimbabwe, has just recently, in the last year or so, initiated a vaccination program, but it's still limited. It's exciting, it's limited though, and so the 9-valent vaccine study is going to be really interesting for us. So I thought the other interesting work was a study that my colleague Tom Campbell presented about Kaposi sarcoma. It was a collaborative AMC 067 and ACTG 5264 study of limited stage KS, Kaposi sarcoma. To be honest, the majority of patients that we see actually present with advanced Kaposi sarcoma, but this was interesting, and in the session today, Tom presented the data looking at iris responses in
iris
patients.
for our audience,
So iris is an immune reconstitution inflammatory syndrome. So when we put patients on antiretroviral therapy, there are opportunistic infections, and Kaposi's is probably an opportunistic cancer in that it's caused by a virus, which may get worse when the immune system starts to reconstitute. And so Tom's presentation today was on A5264, which was dividing patients into two groups, one who just received antiretroviral therapy alone, and one who received antiretroviral therapy with immediate oral chemotherapy called etoposide, which is interesting because it's not widely used, although there is some older data that suggested that it was useful. And it was very interesting because it did in fact show that the immediate etoposide arm did improve the number of iris responses, but the effects at a year, at 48 weeks, were similar in the group. So it was a very interesting study, and they're still looking at the molecular and other analyses within that. The other work that I found interesting related to inflammation, actually, and that I was listening to, I think yesterday, which was a study looking at cardiovascular disease and using something called canakinumab.
Right.
And that was very interesting because it was found in that study that the amount of cancer that was found in that group of patients was less than had been anticipated, would have been predicted. And so I think that the work on inflammation was different groups of drugs to impact on inflammation is very interesting. I find the statin work fascinating because statins are widely used, even where I work, and are relatively inexpensive. So effectively repurposing, I suppose, a drug has huge possibilities.
And the investigators who are conducting the Reprieve Study, which is a huge randomized study that will look at whether widespread statin use will prevent serious cardiovascular events. But because the study is so large and so long, they'll also have some cancer endpoints that can be investigated as well.
That's what, 5,000 or 6,000 patients?
Yeah, over 6,000.
Yeah.
And so it's so that will be of a size that they could really make some comments about cancer in a randomized study. Because one limitation for the statin study is that it wasn't randomized. So you can't completely control for why this person was put on a statin and this person was not. So that will be very helpful. And as we get to fixed dose combinations, you could imagine that eventually we could have just a little statin mixed in with the ART and just one pill once a day for
a polypill.
a very polypill.
Very polypill.
A polypill. So I mean, it's exciting.
It is exciting.
Because we have such great ART options. We're really moving on to the other comorbidities and other problems are really, what continue to be the reason that people with HIV are dying is not from their HIV per se, it's from these other cancers, heart attacks, and other things.
Well, certainly with successful treatment, people are living to an age where they would normally start to develop more cancer anyway. So that's all the more important. And in your experience as clinicians, are you seeing a lot more cancers in older people with HIV than you would in the general population?
Yeah, I mean, the data says that, that it's not necessarily a different array of cancers, but just the cancers occur more commonly, so younger ages.
And then how do people respond when they get treatment? Is there a difference between?
I think in general, the treatments, if their HIV is well controlled and they stay on HIV treatment, we expect the treatment results to be similar, but I think there's more limited data. Because people with HIV had been excluded from a lot of clinical trials in the past, although I think that's really changing.
Well, now the newer drugs have fewer interactions, which was the problem.
There's really less of a rationale to exclude people with HIV. Yeah,
that's a good thing.
It's interesting. The pattern of cancer is changing also in Africa, I think. So Kaposi has come down, although it's not come down to the point to which it came down in the US and in Europe.
Well, you have endemic Kaposi's there, right,
yes,
as well?
Absolutely.
Unrelated to HIV.
So, exactly. So we do still see a fair amount of disease. But we are also seeing that changing pattern in that people are living longer on ARVs, even in my KS patients. And what's fascinating is that they are getting tumours too. I'm seeing patients whom I'm looking after with Kaposi's 10 years later getting HPV-related tumours or lymphoma, which is fascinating. I find that really an interesting phenomenon. Just to go back to the Reprieve study, it's now also being done in low-resource settings, and so the information that will be learnt from that study is really going to be have a lot of impact, I think.
How long is the study? When do they expect to start seeing some results?
They are not fully enrolled, and they're nearing completion, and so I think it's supposed to be probably for at least 4 to 5 years after they complete enrollment. I don't know for sure, but a long time.
Yeah, it's a long perspective study.
Yes.
How many CROI's hands?
Yes.
Terrific. Well, I know the HPV is doing some really fascinating large trials as well. One of those is the ANCHOR trial. Would you speak briefly to that?
Yes. So the ANCHOR trial, I mean, we, for cervical cancer, we've just sort of gradually come to accept that treating pre-malignant lesions of the cervix actually prevents cervical cancer. There's really no specific randomized trials that show that, but it's why it's been accepted. However, treating pre-malignant lesions of the anus is a little bit different because people don't respond quite as well to the treatments. The treatments are more difficult, the screening's more difficult. So the ANCHOR study is designed to answer the question, does treating these pre-malignant lesions of the anus actually prevent anal cancer? So it's also a huge study. It's supposed to enroll 5,000 HIV-infected adults with the pre-malignant lesions of the anus and randomize them either to treatment, so you treat and if it recurs you treat again and keep up that pattern, versus active monitoring where we closely watch people in the other group who do not receive treatments, and then at the end we'll compare the number of cancers in the two groups. So we know that cancers can occur even with treatment. And we know that the vast majority of people with these lesions will never develop cancer. So there is really equipoise about this question and a need to do the clinical trial. So it's well underway. There's 15 sites around the US that are participating. Chicago, Los Angeles, San Francisco, Seattle, New York,
Soon to be Palm Springs.
Atlanta, New Orleans, and I'm forgetting a few. So quite a lot, Miami, quite a number of sites.
Puerto Rico, right?
Puerto Rico, yes. So it's definitely a great option for these services. All the providers are excellent and well-trained and certified by world experts that they can do the procedure well. So it's really a great opportunity for patients to get high-quality testing.
Yeah, because that's not available in a lot of areas.
Yes.
I know people living with HIV, especially men.
Yes.
You know,
And there's a big change to the study. Originally, it was only enrolling people who had never had treatments for high cell, but that's changing, and so we are beginning to enroll people who've had treatments in the past where the high cell have recurred. So that will open it up to most everyone.
Terrific.
Yeah.
So another big study that we'll have to wait years to see the results of.
Yes, anchorstudy.org.
Thank you for that plug.
Yes.
Terrific. Anything else that stood out for you at the conference that you'd like to mention?
It's a silver anniversary,
actually,
silver
yeah,
jubilee,
20
25th anniversary
Yeah.
of CROI. So
We have
that's
lots of silver
exciting.
snow to celebrate. So.
Yeah.
Yeah. No, I think that the inflammation work is actually something that we're going to see in years to come,
Yes.
to be honest, don't you think?
Yeah.
Well, yeah, I mean, it impacts so many comorbidities, not just cancer. It's
Systems, organs, and comorbidities.
aging
yeah.
itself.
Absolutely. I think that's really, that's been
And not just
fascinating.
investigating biomarkers and relationships that it's unclear what it means. There's actual treatments that
Exactly.
potentially people can take, so we can actually
Yeah.
make a difference.
Absolutely.
Yeah.
Yeah, it's fascinating. And I think there's huge, I think we're going to hear a lot more in years to come.
Excellent. Well, thank you so much for joining us today.
Thank
We
you.
appreciate it.
Yeah,
Thanks,
well,
Enjoy the rest
thank
of your
you very
conference.
much.
Okay.
Thank you.